Hello everyone, my name is Krista Hales and I am a member of the TiNHiH Board of Directors. I'm a licensed alcohol and drug counselor as well as intern supervisor in the state of Nevada. I currently am the IOTRC director for Center for Behavioral Health. We have 4 treatment centers here in Nevada, 3 in Las Vegas and 1 in Reno. I've worked in medication-assisted treatment for about 8 years now. This presentation is just going to go over some basics about medication-assisted treatment, give you an introduction to the different medications, the history behind it, and some of Center for Behavioral Health statistics. So our objectives today are to review the history of medication-assisted treatment and key legislation, examine the FDA-approved medications in MAT for opioid use disorder treatment. You're going to hear me use the term MAT pretty frequently throughout this presentation, and that does stand for medication-assisted treatment. Another term that you may hear is MAR, which is medication-assisted recovery. We're also going to go over the characteristics of an opioid treatment provider, or an OTP, versus an office-based opioid treatment provider, which is an OBOT. And then we're also going to define statistics for MAT on a national and local level. So usually when I give this presentation in person, the first thing I like to go over is what you know about medication-assisted treatment. So since we're doing this as a recording, I would love to see some comments so that I can respond back. I always find this interesting to see what the group already knows, what they're curious about, what they have questions about, and so forth. So go ahead and comment what you already knew before this presentation. So the history of MAT. So the first medication-assisted treatment option for opioid use disorders was developed in the 1960s in response to the heroin epidemic that happened post-World War II in New York City. So at that time, heroin-related overdoses were the leading cause of death in New York City in young adults, especially those of our service members that were returning home from war. Recognition that traditional avenues of treatment weren't working very well, and there were several attempts at maintenance treatment before this that were also not working well. Methadone maintenance treatment began as a research project at the Rockefeller University in New York City under the direction of Vincent P. Dole and Mary E. Neiswinder. So the Neiswinder and Dole work created the foundation for what we currently use as our model for methadone maintenance treatment. Out of that research project, what they found was that methadone caused no euphoric or analgesic effects when it was provided at a stable dose. Doses between 80 and 120 milligrams held at that level blocked euphoric and tranquilizing effects of any continued opiate misuse. There was no change in tolerance level over time. It could be taken once daily to satisfy the needs of that individual patient. It relieved cravings attributed to relapse, and it was medically safe and non-toxic. So some very important key findings in that study. Some key legislation related to MAT is the Harrison Narcotic Act of 1912. On the surface, it was a tax act on distribution and dispensing of opium and coca. However, some language within the act was later used to prosecute physicians who were providing opium-based products to persons known to have an opium addiction to maintain their habit. And this led to a series of lawsuits and many physicians' arrests. There was also the Narcotic Treatment Act of 1974, which created a requirement that practitioners conducting methadone treatment register as a narcotic treatment program, or an NTP. And the Drug Addiction Treatment Act of 2000, which is also known as the DATA 2000, created a special waiver which allows physicians to prescribe buprenorphine to treat opioid addiction without having to register as a narcotic treatment program. So jumping into the medications, there's currently 3 FDA-approved medications that can be used in medication-assisted treatment for opioid addiction. The first one we're going to talk about is methadone. It is the most controversial of the 3. It is a long-acting synthetic opioid, and it is a full agonist, which means it fully binds to the opioid receptor sites in the brain. It comes in a variety of forms, so there's a pill form, a diskette, and a liquid. Your OTPs, or your opioid treatment providers, are most oftentimes going to use liquid methadone because it has greater dose individualization. You can increase or decrease in 1 milligram increments, and it's also correlated to lower diversion. Most oftentimes, if you find methadone in pill form, it's being prescribed by a pain management doctor for the purpose of pain management. You usually won't see OTPs using it unless the individual patient has some specific medical condition, such as an allergy to the dye in the methadone, or stomach issues that cause them to be not able to tolerate the liquid. When used in proper doses in maintenance treatment, methadone does not create euphoria, sedation, or an analgesic effect. I cannot stress enough there that the key term in that is that it has to be a proper dosage. So if the individual is over-medicated or under-medicated, you may see these problems, but if the individual is on a stable dose, you should not. Doses are individually determined. So this means that there's not set standard dosing requirements based on height, weight, gender, history of use, anything like that. It is solely individualized, and that's determined between the doctor, the nurse, and the patient. So individuals could be a 5'3" female that weigh 100 pounds soaking wet and be comfortable and stable at 100 milligrams of methadone. And then you may have a 6'5", 400-pound male that's comfortable at 35 milligrams. It's solely their individual tolerance level to opioids and what their body is needing to be stable. It can be prescribed by physicians only for the purpose of pain. So if a physician is prescribing methadone out of their office, the patient must have a pain-related diagnosis. And then it can only be administered through an OTP or an opioid treatment provider for the treatment of addiction. So physicians that are just working out of their offices cannot prescribe methadone for the purpose of addiction. This is a graph of a heroin dose response over a 24-hour period. So as you can see, after the initial use, they have their loaded and high feelings. As time progresses, they get into a normal range of their comfort zone. They start to obtain subjective withdrawal symptoms, and then they'll get into their sick or their objective withdrawal symptoms. Not always will this go a full 24 hours, depending on tolerance level. Sometimes individuals hit objective withdrawal within a few hours, depending on how much is their normal range of use. And here is an example of what a methadone dose does in a steady state over the same 24-hour period. So you'll see you have your heroin in the background, and then your methadone dose is this line across here in the middle. Methadone will keep individuals in their normal range, their comfort zone, for a minimum of 32 hours after each dose. And this is why it's suggested to be dosing daily, so that the individual stays in this normal range. Again, keep in mind that this is a stable, steady dose of methadone, not someone that's still adjusting. Buprenorphine is the next medication that's used for opioid treatment. Some individuals have a really difficult time saying this word, so try and practice it after you watch this video a few times. Buprenorphine is a long-acting synthetic opioid. It's a partial agonist, which means that it binds to the receptor sites, but it doesn't stimulate them in any way. It essentially just blocks them. You may hear the brand names for it, which is Suboxone and Zubsolv. These two right here are buprenorphine naloxone combinations, which just means that, as you can see on this top part here, this is a buprenorphine naloxone sublingual film. When it's combined with naloxone, the individual could potentially go into what we call precipitated withdrawal, which is when an individual still has opiates in their system and they take the Suboxone, it puts them into withdrawal. Some individuals like this because they know they can't use or they will be sick if they take their Suboxone dose after using. You have other combinations like Subutex, which is just buprenorphine. It is not the combination drug. You have Sublocade, which is now the injectable version. It goes into the abdomen once every 28 days. And then you have Probufene, which is the subdermal implant, which is this picture right over here. The individual receives 4 of these in their inner arm, and they can get it up to 2 times in each arm. So it switches arm. The implant lasts for 6 months, so it only has to be changed every 6 months. So as you can see, it can be sold as the single product, which is buprenorphine only, or as the combination product, which is buprenorphine naloxone. Most oftentimes, this medication is either taken in the injectable, the implant, or sublingually under the tongue. The combination product reduces the likelihood of diverting the medication to intravenous use, because once it would be injected, naloxone would cause opioid withdrawal symptoms. Buprenorphine can be dispensed through an opioid treatment provider, like Center for Behavioral Health, the program I work for, or it can be given as a prescription by physicians who have applied for that DATA 2000 waiver and are classified as an OBOT, or an office-based opioid treatment provider. Your last medication is Vivitrol. So Vivitrol is a once-a-month injectable form of naltrexone. It was originally approved and is still used for the treatment of alcohol use disorder, and it was later approved for the treatment of opioid use disorder. They are also working on an implant form of naltrexone, but it hasn't been approved by the FDA at this time. Naltrexone is an opioid antagonist, which means it prevents chemicals from binding to receptors. So essentially, it blankets over the top of the receptor sites, making it so that opioids can't bind to it. Because of this, individuals that are starting Vivitrol for opiate use disorder must have already achieved a period of abstinence from illicit opioids. So this means they typically have to go between 7 to 10 days of no use before they can receive their first Vivitrol injection. If being prescribed for alcohol use disorder, the intention is to reduce the amount of alcohol an individual uses per month by making it so that they experience no euphoria when they drink. So, and for alcohol use disorder, this can be given the exact same day as their last use. So there is not a waiting period when it's used for alcohol. Vivitrol's been found to be extremely effective to prevent relapse for individuals that are coming out of an inpatient or detox facility when they've completed either methadone or Suboxone treatment, or when they're coming out of incarceration or a controlled setting. These are the times when people with an opiate use disorder are especially vulnerable to relapse, when they're coming out of a controlled setting. And because they no longer have that tolerance they've built up, they're at a greater risk for an overdose as a result of any potential relapse. So the question I get all the time is how to determine what medication an individual should start. And it is solely patient and provider decision. I cannot stress that enough. is that the patient and the provider have the ultimate decision in this. So usually an individual that's starting methadone has a higher opioid tolerance level. They have a longer history of substance abuse. They are using additional substances on top of their opioids. They have extremely high-risk behaviors in home environments. If there's pregnancy involved, and if there's mental health disorders. The reason why for those last two is methadone is considered the gold standard for treating opiate-using pregnant females, as well as methadone does not have an interaction with most mental health medications. There are some, such as benzodiazepines, that it can have an interaction with, so they have to be monitored closely, but it does allow for a wider range of mental health medications to be used. For Suboxone or any of the formulations of buprenorphine, this typically is an individual that has a lower tolerance, has a shorter history of substance abuse, they have a more stable home environment, and they have few risk-taking behaviors. In order to start the injection or the implant of buprenorphine, so Sublocade or Probufene, for Sublocade, an individual has to be stable on 24 milligrams or less of the oral buprenorphine for at least 7 days before their first injection. And for Probufene, the implant, they have to be stable on 8 milligrams or less of the oral for a minimum of 90 days. They are continuing to work on those time frames and come out with some new standards. However, those are the current standards for those two medications. And for Vivitrol, these are your individuals that are their most stable in their recovery. They have an extremely stable support system. The recovery process has already began before the medication is administered. So as we discussed, this is an individual that has obtained some amount of time of sobriety. Their tolerance level has shifted. They're coming out of a controlled environment, and their chance of relapse is higher, but they've got a good support system to help them get through the rest of their recovery. So the two models for opioid agonist therapy or MAT treatment is an OTP, as we discussed, or an OBOT. So an opioid treatment program or an office-based opioid treatment program. So an OTP or an opioid treatment program directly administers the medication, so methadone or buprenorphine, on a daily basis. They're typically not doing prescriptions. Individuals stable on the medication and abstaining from substance use who are actively engaging in the recovery process and are demonstrating improved overall function can start to earn and accrue take-home medication. So as they start following their treatment plans, stabilizing on their medication, attending their counseling on a regular basis, starting to stabilize their home environment, they can start earning doses to where they don't have to come in every day. OTPs are heavily regulated by federal agencies. So you have CSAT, the DEA, as well as state agencies like the Board of Pharmacy and DHEC. You also have accreditation requirements. So OTPs have to be accredited through CARF, Joint Commission, other national accreditations. There's behavioral interventions involved in treatment, such as individual and group counseling, that are required for the individual to keep getting their medication. And there's low rates of diversion due to the heavy monitoring and required diversion control measures. So for example, at Center for Behavioral Health, individuals that start earning the take-home medication that we talked about, once they achieve a status of what we call level 4 or weekly, where they only come in once a week, we do diversion callbacks, where the individual gets a phone call from a staff member. They have to return to the clinic with all of their medication, their empty bottles and their full. We count, we look at levels in the bottles, measure, check for color, all sorts of, check the seals to make sure the seals on the bottles are still intact to ensure that the individuals are not diverting their medication in any way. Now moving over to an OBOT, so an office-based opioid treatment. Buprenorphine is prescribed specifically by waivered physicians. So any physician that's wanting to do buprenorphine treatment needs to have that Data 2000 waiver. So they can treat up to 30 patients in their first year of having that waiver. After that 1 year, they can apply to increase to a limit of 100. And after 1 year, at the 100 patient limit, they can apply to increase to a limit of 275. And that's the number of patients that they see per month. The actual practice of the individual physicians are guided by federal regulations for an OBOT. However, actual sites and offices are not under regulation or accreditation requirements, and they must be able to demonstrate the capacity to refer for behavioral health treatment. They do not necessarily have to offer it in-house. So services that you might see in an opioid treatment provider that you may not see in an OBOT. Counseling is the biggest one. So counseling is based on individualized treatment plans. Those individualized treatment plans are developed collaboratively with the patients. They're measurable and time specific and are based on the patient's strengths, needs, abilities, and preferences. You also see case management services, which is coordinated referrals to community services and resources, such as medical and dental care, housing, mental health services, etc. You have nurse consultations, so you have care coordination with primary medical providers, assistance with accessing care for communicable diseases, such as Hep C, and psychoeducation on communicable diseases. Patients will receive annual physicals with the doctors. They have random drug screening that they must comply with, as well as they receive their medication that they're taking once daily for the management of their withdrawal and cravings. Admission criteria for an OTP is pretty stringent. So individuals must be 18 years of age or older. If they are under the age of 18, they need to have 2 failed treatment attempts and parental consent. So most oftentimes you're not going to see an individual under the age of 18 seeking out MAT treatment. There must be a minimum of 1 year history of opioid addiction, and this is to address for methadone treatment. If they have less than 1 year, they are still eligible to enter buprenorphine treatment. The individual must meet criteria for an opioid use disorder based on the DSM-5, and the admission process is pretty lengthy. So there's going to be a screening to ensure that they meet all of those admission criteria. There's a biopsychosocial assessment, so we get a full history on the patient. There's a physical exam by the program physician or medical director. There's a health history and communicable disease risk screening done on all patients. They provide a urine drug screen. And then there is some blood work. So an RPR to test for syphilis, a TB test to test for tuberculosis, and potentially a few other blood work depending on the patient's status. So the effectiveness of MAT. So this is a few statistics you'll see there on the bottom where they came from, but with over 50 years to support it, methadone treatment is considered the most effective treatment for chronic heroin dependence. According to TiNHiH, the safety and efficacy of MAT has been unequivocally established. Methadone maintenance, coupled with relevant social, medical, psychological services, has the highest probability of being the most effective of all treatments for opioid addiction. One study found that those who receive MAT are 75% less likely to have an addiction-related death than those who do not receive MAT. MAT has been shown to improve patient survival rates, increase retention in treatment, decrease illicit opiate use and other criminal activity, increase patients' ability to gain and maintain employment, improve birth outcomes among women who have substance use disorders and are pregnant, and lower a person's risk of contracting HIV or Hep C by reducing their potential for relapse or high-risk behaviors. So again, the documented outcomes of MAT are reduction in use of opioids and all illicit drugs, reduction in criminal activity, reduction in needle sharing, reduction in HIV and hepatitis B and C infection rates, reduction in commercial sex work, reduction in the number of reports of multiple sex partners, reduction in suicide, reduction in lethal overdose, improvements in social health and productivity, improvements in health conditions, and retention in treatment. So just some Center for Behavioral Health Nevada statistics to give you a look at more what's happening right here in our state within Center for Behavioral Health. And just to give you an idea, we have approximately about 2,800 patients that we're currently treating in our medication-assisted treatment program. So we do treat a significant number of patients in the state. So 14% of our patients have an increase in adequate employment within the first 5 months of their treatment after admission. 15% have an increase in physical health improvement within 1 year of admission. 21% have an increase in mental health improvement within 6 months of admission. Most oftentimes I get asked why those numbers aren't higher in physical health and mental health. And that's typically because individuals are self-medicating with their opiate use. And when they get into treatment and obtain sobriety, they are now noticing physical ailments or mental health ailments that they need to address in other manners. And sometimes that comes as a shock to them. So those numbers aren't as high as you would think they would be, solely because there's individuals that may have rated their health as fair and then have now been diagnosed with a physical or mental health condition. And so they're rating their health as poor because they now have this additional condition on their medical record. 37% of the patients have a decrease in intravenous or intramuscular substance use within their first year of admission. 96% of patients report no use or reduced use within 1 year of admission. The key thing to remember there is that medication-assisted treatment is a harm reduction approach. So it's meeting the individual where they're at, not leaving them there, and showing them the steps to make sure that they're safe if they are going to have continued use. So reduced use is considered a success. 66% reduction in discharge rate since implementing additional services. So since providing our patients with peer support, mental health counseling, syringe access, all of these additional services in-house, there's been a reduction of our discharges by 66%. We are a location for the syringe vending machines, the harm reduction vending machines that our local syringe exchange program Track B provides. So we have 2 of those in our treatment centers. We're the only treatment centers in the nation that have those machines. And we've seen great success in individuals coming in just for accessing the machine, getting comfortable with staff, starting to ask questions, and eventually entering treatment to address their use. The cost benefits of medication-assisted treatment are astounding. So the average cost for a full year of methadone maintenance treatment is approximately $4,700 per patient. Yet 1 year of imprisonment costs the state about $18,400 per person. So significantly less to get into treatment versus continued criminal activity and ending up in jail or prison. A review of literature on the cost benefit and cost effectiveness of MET concluded that methadone and buprenorphine are both cost-effective treatments for heroin or other opioid addiction, and that methadone is typically the most cost-effective therapy of the 2. So in 2004, a study evaluating the incremental cost-effectiveness of sustained methadone maintenance relative to a 180-day methadone detox found that methadone maintenance yielded better outcomes, including reduced opioid use and lower subsequent behavioral health care costs, and a cost-effectiveness ratio of approximately $20,000 per life year gained. So individuals gained years back on their life by engaging in a maintenance program versus a detox program. A 2010 study of extended buprenorphine naloxone treatment for opioid-dependent youth estimated that the cost-effectiveness ratio for buprenorphine compared to detox was 29,415 years per quality adjusted life year. So again, gaining life years back that are quality and saving this amount of money. The reason why MAT continues to be underutilized is because of stigma related to MAT. So it is estimated that nearly 80% of individuals with an opiate use disorder in the US are currently not receiving treatment for it. In 2010, only 28% of admissions for a heroin use disorder into a treatment center had a treatment plan that included MAT. Only 5.5% of individuals enrolled in methadone treatment were referred by systems in which the person with a heroin use disorder are most likely to encounter. So only 5.5% of referrals come from healthcare and criminal justice system, and that's where you're most often going to find your individuals that could be diagnosed with an opioid use disorder. So 9.6 were referred by other treatment providers, 4.2 were referred by healthcare providers, 6.1 were referred by other community referrals, and 72.8 were referred by a friend or family member. So as I stated, stigma tends to be the reason why most individuals do not seek out MAT treatment. Some of the stigma that's commonly heard is that there's a belief that they're just using the medication to get high. The reality, and we kind of went over this when we discussed the medications, is that methadone and buprenorphine at stable doses do not produce euphoria. There's been numerous studies done on methadone maintenance patients that show that methadone used as medication in MAT or MMT does not hinder a person's ability to function in any mental or intellectual capacity, again, at stable doses. Another stigma and myth is that it's simply substituting one drug for another. So there's two realities to this. The reality is that medications used in treatment for opiate use disorder are fundamentally different than short-acting opioids that are commonly misused. There's also research that confirms improved opioid systems, including the hypothalamic pituitary adrenal axis, which affects stress, response, immunity, and other systems. If the individual is on methadone or buprenorphine versus using heroin or oxycodone or any of those other opioids off the street. A common stigma that I hear is you just want to keep them on treatment for life, or you're enabling them by keeping them on medication, or it's just a crutch. So the reality here is that research consistently shows better outcomes with adequate treatment length. So as we talked about in a previous slide, methadone detoxification over a 180-day period versus maintenance, there's more successful outcomes with maintenance treatment. Studies show longer lengths of times in methadone treatment yields better outcomes. For some, remaining on the medication long-term may provide the best likelihood of sustained recovery and well-being for that individual. Medication-assisted recovery, or MAR, like I talked about in the beginning, is a non-stigmatizing description that recovery can be made possible through the successful use of MAT. No medication can cure an opiate use disorder. Once you have it, you have it. However, medication can play a role in helping individuals achieve that long-term recovery. Also, the use of medications in the management of chronic disease is not new. Addiction is a chronic disease, and there are numerous chronic diseases that we treat with medication. Just to give you an idea, MAT patients come from all walks of life. So MAT patients are people who use heroin or opioid pain pills. They're bartenders, they're sex industry workers, they're pregnant women, they're construction workers, mechanics, school teachers. nurses, social workers, lawyers, business owners, politicians, veterans, you name it, someone from that category is potentially a MAT patient. I've seen all walks of life come into our clinics in the 8 years I've been doing this. Everyone from homeless veterans to business owners to CEOs to famous families and so forth. So addiction does not discriminate. Opiate use disorder does not discriminate, and we need to keep that in the back of our heads, because odds are that you potentially have interacted with someone today that has an opiate use disorder and potentially someone that is a MAT patient. I always like to show this slide towards the end of my presentation because this really gives an idea of how we treat addiction versus how we treat other chronic diseases. So diabetes is very, very common in the United States. I don't know the exact statistics on it because I'm not a medical professional right now, but I do know it's a pretty common condition nowadays. So with diabetes, you have genetic predisposition to diabetes. You also have lifestyle choices that can factor into the development of the disease. There's severity that is variable. There are diagnostic criteria in order to obtain diabetes diagnosis. Once you've been diagnosed with it, you have it. You have to start doing things to monitor it and to stabilize it. The primary treatment initially for diabetes is lifestyle modification, and we can use medications to assist in that process. When the patient is non-compliant with lifestyle modifications, so things such as exercise and diet, we use medication to maximize the outcome and to stabilize that patient. When you look at addiction, you also have a genetic predisposition. You have lifestyle choices that factor into the development of the disease. Severity is variable. There's diagnostic criteria. Once you've been diagnosed, you have it. Primary treatment is always lifestyle modification. Medications can also help. When you have a patient that's non-compliant with lifestyle medication, our immediate reaction is usually they don't want it bad enough. We're going to admin discharge them from the program. Let's wait until they're motivated to get back into treatment. Let's withhold their medication until they try harder. Yet we don't do this with patients that get a diabetes diagnosis. So we need to start treating the two one and the same, because when you break them down, as you can see, they're identical. It's just a different chronic disease. Yet we have stigma that prevents us from treating it appropriately. I'm not one to say that medication-assisted treatment is for everyone, just like detox is not for everyone, residential is not for everyone. There is something that's going to support someone in their recovery process, but we need to have all options on the table when we approach that individual. I want to thank you all for listening to me. If you have any questions about medication-assisted treatment, you can reach out to me at my work email. You can go on to our resources tab on our website at the Center for Behavioral Health website and watch the patient orientation video. It's about 15 minutes and it will give you a little bit more of a look into what we do. Or you can comment on this video and I will respond to you on here if you don't care about the public seeing what questions you have. I greatly appreciate you spending some time with me today, and please let me know if you have any questions.